Hello. Can everybody can everybody hear me? Thumbs up if you can. Perfect. All right. I'm Dr. Rachel Raphael from Advent Health the Land, although I do some surgeries at Fish Memorial there nearby. I am here to speak about breast health as well as thyroid health. And actually, they just got my whole audience seems to be perfect for that. So hopefully I can actually tell you, answer all questions that you have as well. So let's get started, maybe. Let's do it that way. So we'll go, the overview of the whole talk will be, we'll talk about breast cancer, some statistics there, the risk factors associated with that, as well as, once you're diagnosed, then what happens, and then we'll talk about a few resources for that, and then we'll go into thyroid gland. I am primarily subspecialized in endocrine surgery, so that's a little baby of mine, thyroids and parathyroid disease, as well as breast, obviously. And we'll talk about hypothyroidism, hyperthyroidism, some of the most common associated diseases of the thyroid gland, as well as thyroid tumors, nodules, and what they mean. Okay. I forget this thing doesn't work. Okay, so we'll start out with breast cancer, and if you want me to break it so that we can answer some questions about breast cancer first, and then go into thyroid, or do you want me to do breast, thyroid, and then questions at the end? What do you guys think? All right, I'll choose. If you guys look like you're gonna be falling asleep by halfway through, then I'll have some questions. It's a very common disease among women, so it's about 255,000 cases that the World Health Organization predicts that will be diagnosis for the year in 2023, that was. And this is mainly affecting women. It's more common for women, as you can tell. It's 1 in 8 women that are affected, and 1 in 100 men. Usually it is the second most common cancer diagnosed in women. Skin cancer is number 1. And it's the second leading cause of cancer death in women, and that's after lung cancer. Now, when we look at what are risk factors, what increases your risk of having breast cancer, age is really up there, because the older you are, the more likely chance of you being diagnosed with breast cancer. Yes, more and more younger patients are affected, but age is a factor. And genetic risk. Some people have genetic mutations that make them more likely to have breast cancer. Some of the most common one that you folks probably hear about are BRCA genes, 1 and 2. And when we know that someone has family history of breast cancer, especially in mother, daughter, sisters, first cousins, these are red flags to make us think that, okay, you are at higher risk of getting it. And then the length of time that you actually are exposed to hormones such as estrogen hormones and progesterone. So when we ask you, your doctors probably ask you sometimes, when did you first start having your period and when did you stop? The reason they're asking that is to see how long of a period that you were exposed to these hormones. And Unfortunately, if you stopped having your period and you continue to take in hormone replacement therapy, that increases your exposure to hormones. So that's another question that's asked. Because they increase your risk of breast cancer because hormone stimulated. Same reason why we would ask, oh, how many children that you had and did you breastfeed? Because believe it or not, the children are protective in this case because the period of time that you're pregnant and the period of time that you're breastfeeding kind of like cancel out that, they take a few years off for you. And obviously dense breast increases the risk of having breast cancer. If you had a personal history of breast cancer, so if you had breast cancer before, you are more prone to having it again. And as mentioned above, breast cancer as well as ovarian cancer in the family history, both increase your risk. Decreased physical activity as well as obesity, but obesity after menopause is more, when you look at research, it's more associated with the increased risk. So being physically active, I don't know if you have a gym here, but keep going and actually participate in exercise. It helps. Hormone replacement therapy, as mentioned before, and some oral contraceptives, not all, increase your risk. And as this is like, I always put it at the bottom because of the fact that it's research that usually makes people say, oh no, I'm not giving up my glass of wine every day. But alcohol use increases the risk of having breast cancer. So, and as far, yeah, exactly. That's the reaction I get, because as far as we know, there's not a set amount that is acceptable. I can't really say that, oh, just a glass a day should be okay. Any alcohol use increases the risk of breast cancer. And now that you are all thinking that, forget it, send her out there, she doesn't know what she's talking about. If you are unfortunate enough to be diagnosed with breast cancer, it is cancer, but we are making huge leaps as far as treating it and you having a meaningful life after diagnosis. So Advent Health, of course, I am a physician of Advent Health, and they basically have programs where you are within, you basically meet with, if they don't have a system where you go into one building and you meet everybody, usually they do. If they don't, what happens is that they have a navigator. My navigator was going to be here today, but I'm not sure. She probably will walk in at some point. But the breast navigator helps us to connect every member of the treatment team so that you're not lost in the whole system. And there's plenty of resources for patients. Now, what happens, usually you get diagnosed either because you palpated a mass, you felt a mass in your breast, or there was some skin problems, or there was some nipple discharge. But the most common reason people come to be evaluated is because they felt a mass. Now that I want you to think of as that's very late in the game. What you want to do is be diagnosed early. And the only way that you can be diagnosed early is if you go for your yearly mammogram. And that's what helps you find it, and you find it when it's very small. Because when it's very small, you get all options for treatment that won't necessarily be available when you find it, when it's a big mass that you can feel, okay? So there's the diagnosis. They send you to see me, and what's next? Most of the time, it is surgery first, most of the time. Now, the reason I say that is because depending on the type of breast cancer, you may start out needing chemotherapy. And obviously, depending on how advanced it is, you may again start out needing chemotherapy first and then surgery afterwards. Now, there, aside from surgery, that's basically cutting out the cancer. Radiation is another treatment where we use high X-rays to kill any remaining cells in the breast, and then chemotherapy. Now, well, I thought I went into details for that. With surgery, there are a number of options. You can have what is called a lumpectomy, which is where we remove the cancer and we remove a little bit of normal tissue around the cancer, okay? The rest of your breast stays intact. After that type of surgery, most people end up with radiation. Radiation treatment, like I say, high beam radiation, X-rays, to kill the remaining cancer cells, if there are any after surgery. Then there is what is called a mastectomy. That's removing the breast tissue, all the breast tissue. And that usually is very, it's a very different and invasive type of surgery. I find it is because of the fact that you are now removing your whole breast, okay? I would say the majority of the patients that I have that come to see me, they don't need a mastectomy. Some do, because if the cancer is large and there's no remaining breast, or it's invading into other things, then yes, you would need that. If you are not eligible for chemotherapy to shrink it, okay? Because that's another reason why sometimes we do chemotherapy. We try to shrink the tumor so that you don't have to lose your whole breast, okay? Radiation therapy usually after, if you have to have some type of chemotherapy, you get that done, and then you have radiation therapy. And it is going to not only address any remaining cancer cells in the breast, but also in the underarms, because if the cancer went outside of your breast, most of the time the first place that it goes to is the underarm. We call it the axilla, and radiation can kill those cells as well that escape to the axilla. Okay. Now, after treatment, we obviously follow you for many years. Usually the first 2 years you follow with your surgeon, and then after that, it's just with the medical oncologist. So those people that I mentioned, the surgeon does the surgery, right? And then the medical oncologist does things like chemotherapy, hormone therapy, and they follow you along over time to make sure that the cancer is not coming back and you're doing well. And then when it seems as if it's not returning, then they release you to your primary care physician. Now, so a few things that I want to make sure that you understand is it's very important to get your mammogram. I don't know if I said that before, but I'm going to say it again and again and again, because the cancers that I like to see are the ones that are small, and I'm going to look you in the face and say, oh, you have all the best options. You can choose whatever you want as far as treatment, and you'll be fine. That's the kind that's fine for me. And the way that it happens is if you do go for your mammogram and follow up diligently, and in some cases you will see that it is the recent recommendation says every other year mammogram, but the American Association of Breast Surgeons still tell you that you have to get the mammogram every year after the age of 40. I said the age of 40, but if you have family members that had cancers at an earlier age, we choose an earlier age to start screening you, okay? And people do tell me that it's a long time. Well, it doesn't really take that long. It's about 30 minutes at any of these centers. We do use at Advent Health 3D mammography that makes the picture better for the radiologist to see things, especially if you have dense breasts. And if anybody want to learn more about what we just discussed or any more information on what the resources are, there's a website. It's called leadingbreastcare.com, and that will give you any type of information that you would like. Now, I am going to stop there and see if anybody has questions about breast. Okay. Mm-hmm. Oh, yeah. You want to write that down? Okay. Leadingbreastcare.com. Leading, Leading, breastcare.com. Anything else? Yeah? So it's interesting. I was talking to one of my patients last week who is 90 years old, and she was told that same thing. And I don't know what it was that happened to her that she decided to go and get her mammogram done, and turns out that she did have a lesion that was suspicious, and it was biopsied and it was cancer. Now, there is no reason why, if you are a healthy individual, no matter your age, and you are out and about, why you shouldn't request a mammogram. So you can always ask your primary for a mammogram, despite that age limit. The reason why they have that is because, obviously, resources, right? Less people getting mammograms. But if you are healthy and you're doing well, and you know that if you had cancer, you would want to have surgery to fix it so that you don't succumb from it, then go ahead and get your mammogram and ask for your primary to order it. Anything else? Oh, really? All right. Well, if you think of anything while I talk about this, you can always ask me. We can always go back. So let's go to the thyroid gland. Now, usually this gland sits in the front of the neck here, and its big job essentially is metabolism, right? I'm pretty sure some of you in the audience take thyroid medication. The fact is, it's responsible for the rate your body is using calories that you take in, food that you take in. It's also has a role in slowing down or speeding up your heart rate. It also helps with controlling the body temperature, and as well as how fast the food is moving through your intestines, your digestive tract. It it helps with muscle contraction and controlling it. It helps with skin and bone maintenance. It controls the rate at which the body replaces dying cells. So when you have someone who comes to you and say, oh yeah, I have thyroid problems and I have dry skin, or I have falling out, my hair is falling out, that's because the thyroid controls a lot of that. It also controls brain development. It's interesting how some people find that having a low functioning thyroid make them slower as far as like thoughts processes, okay? There are different problems that can affect the thyroid, but none more common than this problem right here. It's called hypothyroidism. That is when the thyroid does not function well and it's not making the hormones that it's supposed to make. And this is very common in women, okay? Now, we call it, you probably hear of it as underactive thyroid, okay? Now, a number of things can cause thyroid to become underactive. First of all, I could cause it by doing surgery. If you had some type of cancer and I remove the thyroid, or some type of problems and I remove the thyroid, obviously you're going to have low function because you don't have one. Or you could have part of it removed and it has low function. Well, I usually find out when I do that, and we'll fix it. So the way we fix it is with medicine. We'll fix it. But another way that it actually can happen is disease primarily from chronic inflammation of the thyroid gland. And this can happen, and most commonly happen, because of autoimmune diseases. I don't know if you're familiar with autoimmune diseases. They are diseases where your body is supposed to have the immune system fight other things like bacteria, cancer cells, all these other things, right? But instead of fighting these, it's turning inwards and fighting your organs. And so one of them is Hashimoto's thyroiditis. It is when the immune system is attacking the thyroid, and then you have chronic inflammation of the thyroid. And usually it takes a number of years before the thyroid then dies and does not do anything, and then it's not producing the hormones that it's supposed to. And any other type of chronic inflammation can cause that to the thyroid, right? So now what happens if it starts not producing? Remember what I told you the thyroid does. Well, in these cases, you would notice that you have unexplained weight gain. No matter what, you could go on a diet. As far as like food is concerned, you could work out all you want, exercising, but you still continue to gain weight. So that's one of the big symptoms that people present with when they have underactive thyroid. Slower heart rate, and intolerance to cold. That is just to say, today you walk in here and this is very nicely controlled room, and you would still need sweaters because you feel cold, right? And as I mentioned, dry skin, irregular menstrual cycle. And usually how we treat it is by giving you medications, well-tolerated medication. It's been there forever. And you have to technically be on that medication for the rest of your life, because most of the time the thyroid doesn't just bounce back and start working again, okay? So that's usually how we treat it. Then there is hyperthyroidism, less common than hypothyroidism. This is the opposite problem that you have with these. Now your thyroid is making too much hormones, And usually, Graves' disease, another autoimmune disease, that's when the gland now becomes larger, it's making a lot of hormones, and also sometimes if you have a goiter from, some people have family where they are genetically predisposed to have a larger gland, and so it just gets bigger and bigger and bigger and bigger, and then it starts producing more hormones because of that. That can also cause hyperactive, overactive thyroid gland. And usually it can cause the unexplained weight loss. Nobody ever complains about that part. You could eat all you want and still lose a bunch of weight. A fast heart rate, that's one of the main things that people present to the emergency room for, because their heart is going too fast. And you can be in sub-0 degree weather and feel hot, yet moist skin, irregular menstrual cycle also. Now, we have different ways of treating this one, because we don't know, depending on what causes it, you treat it differently. If it is caused by that autoimmune disease, Graves' disease, we could just give you medication to slow the thyroid down, and that usually works. And sometimes if that doesn't work, then we intentionally kill the thyroid by giving you a pill that kills it, essentially. And then once we kill it, then we give you thyroid medication to help you. And then obviously surgery, and that's removing the gland itself, okay? Now, depending on the type of problem that you have, like for example, if you have a goiter that's doing that, well, most of the time medication won't work, you just have to take out the thyroid gland, okay? Now, thyroid tumors, I see more people with this than I see hypothyroidism or hyperthyroidism, because both problems that I talked to you about can be treated with medication like 99% of the time. But when you have thyroid tumors, such as thyroid nodules, you'll hear people call them, then people start thinking, oh, okay, what is this? Is this okay? Is this not okay? And usually I see people for that. Now, in this room, if I had like 100 of you, 50 of you would have thyroid nodules. That's how common it is in women. 50% of women have thyroid nodules. So, or automatically, there's quite a bit of you that would have it. And we have to eliminate those who need anything done about it versus not. Most of the time, the way we do that is we find out, is it causing the thyroid gland to become overactive or underactive? Is it actually a large tumor, or is it a small little one? What does it look like? So the first thing you'll see that we do is we check your thyroid level. That's a blood test that will tell us if it's active or if it's underactive. If it is something where it's perfectly normal, because sometimes you have these nodules and your thyroid function perfectly well. So once we figure out that, oh yeah, it's perfectly normal, now we have to investigate it further. So most of the time we do an ultrasound of the thyroid. And the ultrasound will tell us whether it's big, whether it looks suspicious, and whether it looks like run-of-the-mill thyroid nodule that nobody cares about. So depending on what it shows, we do a biopsy if it looks suspicious. And then the biopsy is a tiny little needle that I put in. Most people don't hate me after I do that. And we send it to the lab, and they show whether or not it is fine or whether or not it is cancer. If it is cancer, we treat it. If it is fine, if it is not causing you a problem, because sometimes they're so big that people come and they say, I can't swallow well, or my pill gets stuck when I swallow, you know. And then they don't care if I tell them that it's perfectly benign, it's not cancer. They're like, no, get it out. It's causing me problem. Or it's so big that it's pushing on things and you can't breathe properly. They want it out. That's fine, we do that. Now, if it is benign and it's not causing you any problem, most of the time what we do is we tell you, come back in a year, take a look at it with ultrasound, and if it seems like it's stable, because some of those things are present for decades before you even know that they're there, then we leave you alone. You don't need anything for that, okay? If, however, they come back and it is cancer, the most common treatment for thyroid cancer is removing that. And we are actually going even further now that we know that we can just remove the half that has the cancer, and then if the other half is normal, because remember, I show you it's a gland that's like in the middle, but it has one side and then another side. So you could take one side and leave the other side, and it'll be fine. For cancers, depending on the type, you could remove one side and leave the other side, no problem. But most of the time, both sides get to be removed, and then you get to be on medication to replace what it does. I find that the one reason why I actually went into endocrine surgery was because of the fact that most of the time I tell anybody who has thyroid cancer that I just finished treating that you'll be fine, you don't need me anymore, you'll be living long life because this is a very non-aggressive cancer. Most of the time. Very rarely there is a sort that is called anaplastic thyroid cancer that's pretty aggressive, but it's very rare. And usually surgery does the treatment. If for some reason it had gone to the rest of the body or it went to the lymph nodes, and you need additional treatment, it usually does not mean chemotherapy like other cancers. It just means you take one pill that is basically nuclear pill. It goes to the rest of your body, kills the thyroid cells that have gone outside, and nothing else. So nobody ever loses their hair because of this treatment. They're fine after they take that one pill, and that's the beautiful part about it. It's a very treatable, well-treated type of thyroid cancer. Okay. Now, we have other types of thyroid tumors. Well, goiters, multinodular goiters. So you could have one tumor, or you could have a bunch of tumors all making the thyroid larger. That is called the goiter. Multinodular goiter. And sometimes the size of it is causing problems for most people, and you have to remove them, surgically remove them. So that's not. Sometimes they are a bunch of nodules, and they cause you to have high overfunctioning of the thyroid gland. And that's the reason why sometimes we remove those. So they are called multinodular goiter, toxic if it is causing a lot of thyroid hormones, or non-toxic if it's just large and it doesn't cause any problems. And depending on which type, you could have multiple nodules and it's goiter, but if it's not causing you problems, we say, okay, I'll see you next year for an ultrasound. You don't need anything. And if it's causing you a problem, we remove it. Okay, I think I talked quite a bit already. Now, you better have questions for this side. All right, go. So when you first start with that, I always say a yearly. And if it looks as if every year I come and this thing is like, oh yeah, it's just the same size, it's the same size, then I say every other year. Then if it's the same size, then I say, okay, 5 years from now, or, you know, that's how you do it. But when you first find out, every year you want to do.
Every 2 years. Is this working?
That must mean it's pretty stable.
Yes.
Yeah.
Now, Hashimoto's disease, how does it change? I was diagnosed with that 20 years ago too, and I haven't ever heard anything else about it.
It doesn't. It basically is one of those disease processes. I tell people, I'm just going to tell you about this diagnosis. It can ultimately kill the thyroid, and then you have to take thyroid medication. So every year, whenever you get your blood work done, your primary will check the level of the thyroid function to make sure that they're not missing that the thyroid stopped working. But it stays there, and you just live with it, essentially.
Thank you.
Anything else? All right.
Is it sometimes hard to adjust the thyroid medications once you've had the thyroid removed?
Once it's removed, no, it's very easy to do. It's when it's there that it's a problem. So the reason why I say that is because once it's removed, unless you have like intolerance to the medication and they have to switch you to some other brand or something like that, there's nothing that's competing, that's making any hormones. So technically, it should be easy to fix the dose that you need once it's removed. But when it's there, what's happening, especially like if you have Hashimoto's, for example, right? The way that Hashimoto's work is that you have times when if you have a lot of stress going on in your life, it will be right there causing you trouble and spewing out hormones, and then you feel you're back to normal, or whatever stress you had is gone, and your immune system is back to being low again, and then it doesn't do any spewing of hormones. And now imagine if you had medication on board and then this happens and it's spewing out a lot of hormones, so the endocrinologist is like, oh, okay, I have to give you less medication. And then you're back to normal again, and then they have to switch it back to your prior dose. So the thyroid being present is what makes it hard for you to control it. Sometimes they have people that it's doing this so often that the endocrinologist will tell me, get it out so that I can control the medication. Yeah.
Okay.
Mm-hmm.
Are there any over-the-counter medications that affect the thyroid?
Yeah, some. Very few, but some do. Especially if you have inflammation of the thyroid, then yes. But if it's pretty normal, you shouldn't really be worried about that. Yeah.
Is this hereditary?
Yes, most thyroid problems are. So for any of the autoimmune diseases, they pass on, and it's kind of funny. It comes from mother to daughter and sisters all together, and it tends to skip men sometimes, but sometimes they're not so lucky and they still inherit that and they still get thyroid problems based on that. But it is in the sense that some of it is because of your genetic makeup that you end up with the autoimmune disease to begin with. Yeah.
Could you speak to the use of iodized salt?
Oh, yes. So, do you know the story behind it? They actually started adding iodine to salt because of this region of the United States that the food that you grew did not have, because the soil did not have iodine in it, and so you didn't have enough of the iodine present in your system. So you ended up with iodine deficiency because you weren't taking food that had enough of it. So the government, the way they did that, because these people ended up with a lot of goiters, big thyroid. So the thyroid uses iodine to make its hormone. So if it doesn't have enough of it, it's thinking, I just need to grow bigger. I just need to grow bigger. And so it keeps growing and growing, and these people would end up with those large goiters. And it turns out it's because they were deficient in iodine. So they started putting iodine and salt to help, because salt, most people use salt to cook, right? So they thought, let me just put it in a product that I know everybody's gonna use to kind of get iodine in. And so that's why they have iodinized salt. But some people now are being fancy, and they don't take this salt, and they take some other type of salt, and so they end up with deficiencies because of that. But for the most part, it's supposed to protect you, to actually get you the iodine if you're not getting it in enough food. Now, where you are, it shouldn't be a problem, but if you're in Ohio or something, I don't think nowadays it's a big problem, because sometimes some people actually don't take that type of salt. They don't cook with it. But they take supplements, so it kind of cancels out them not taking that salt. Does that answer your question?
Yes,
No.
thank you.
Perfect. I know I went into a whole little story. You shouldn't have asked, but go ahead. Anybody else?
Because of surgery, I've been on thyroid medication since the late 70s, and I was never told along the way that you should take it on an empty stomach. And it's only been in the last 10 years or so that I heard that, and so now I do, but it doesn't seem to react any differently than when I took it at night on a non-empty
Yeah. So it is a pretty selfish medication. It likes to be the only thing in your stomach and get absorbed better that way. So usually I tell my patients, you start it first thing in the morning, and then you wait about a half hour, then you can eat breakfast and have other stuff, but it doesn't like to be absorbed, because sometimes you'll have some people who are on thyroid medication and then they're gaining weight, and you're like, wait a minute, I have you on the perfect dose, why are you gaining weight? And you find out that, they're eating with it, and that's because then it doesn't get absorbed very well. So, yeah. Uh-huh. Oh, yes. At the land, we do that all the time. Mm-hmm. Yeah.
Yeah, hi. I just want to be sure I understand. I don't salt anything. So if I am not getting enough iodine, would that cause hypothyroidism?
Yes, because technically the iodine in the food, I mean, you might think that because you're not salting anything, that you're not getting any iodine, but for the most part nowadays we're putting iodine in some of the stuff that, if you buy anything, and if you eat fish and all that, you're fine. But the fact is, if you wanted to avoid salt, you could just take iodine. Because technically, yes, it can cause you to be hypoactive. Why? Because iodine is what the gland uses to make hormone. And if you don't have enough of it, then yeah, it'll cause that.
I'm going to ask a very off-the-wall question that probably nobody cares about. But I have had 2 cats with hyperthyroidism, and they were put on medications, but the medication either didn't work or they didn't tolerate it. Anyway, both of these cats were taken to a special thyroid center where they were given 1 shot of I-131 radioactive, and what I wanted, and it cured. It was a cure. They never had another problem. I see all the cat people looking at me. It's true. There was a total cure. So my question is, why don't we have something like that?
We do. That's what I was going to suggest. We do. That's the ablation. Yeah. All right. Very well. Well, no questions. It was a pleasure talking to you all.